All right. Good morning, everybody. How's everybody doing this morning? Good. Love that. All right. So Jasmine and I looked at the LESS test and its association with self-reported surveys, and we'll get a little bit into those surveys as we go on. We don't have anything to disclose. All right. So we know that injuries are common in ROTC cadets, and the LESS test has been proven to be a valid test in identifying who has been susceptible to a lower extremity injury. But our problem is that ROTC cadets do not have access to an athletic trainer. So it makes it difficult for them to rule in or out the people who may be at a higher risk for injury or who needs to go spend more time in the athletic training room with the athletic trainer and do those rehabilitation exercises. And also the surveys would come in and serve as a surrogate to help us see who actually needs help as well. And then our purpose is to assess the potential for using function and health-related survey responses to identify ROTC cadets with poor jump landing kinematics and who also have a poor jump landing. All right, so for our participants, we had a total of our 34 ROTC cadets that are on campus at UTC. So they just have your typical demographics of a college student, nothing really special. And then so for our methods, we had a cross-sectional cohort study. For our state variable for the landing error scoring system that we use is a less than or equal to 5 for the LESS score. And then also we had our predictors that we use. So as mentioned before in the other presentations, we had our sport fitness index and then our overall wellness index and then our SFWI, which is a combination of the two surveys together, which we use as our predictors to help predict how the cadets would possibly do on the LESS. So the first one that we have is our sports fitness index. Mainly the questions are musculoskeletal based. There may be a couple of questions psychosocial as well. It's to measure how their daily life and performance is going after a certain amount of time that an injury has occurred. The scale, so as you see, we don't have it here, but it's 0, 1, 2, 3, 4, and 5 is how it's measured. And when we combined, when we did the total math, it basically came out to be high is good and low is bad. All right, so as mentioned, the SFI is more musculoskeletal, except for that last question, number 10, that looked at the psychosocial variable, as well as the overall wellness index. It's more just overall wellness of the individual. So there was a total of 82 symptoms that are grouped into 10 categories, and the score lies between that 0 to 100. So essentially, you go to the next one too. And that's the other set of questions as well. So essentially, the cadets are using the OWI to identify and rate how frequently they have experienced these things and also how recently they have experienced them as well. And as far as the landing error score system goes, so this is where we had to score the videos, and this is considered to be a counter movement jump. So each of the ROTC cadets were given instructions on how to jump off of the box. So they were instructed to have both feet at the edge of the box, and then when they jump off at the box, their feet must leave at the same time. So when they jump down, it'll be here, and they need to pop back up immediately to make it a fluid motion in order for it to be successful. Go to the next slide. And then this is our list of all the indicators of poor jumping landing mechanics. So they're split up, so most of them are either frontal or that sagittal plane. And according to research, we know that a LESS score of greater than or equal to 5 is the cutoff point. So anything higher than that is considered bad. So there's a list of 17 items. You either get a 1 or a 0. The 1 is indicating that it's bad, and 0 is indicating that it's good. And again, we scored them in the frontal and sagittal plane. And then that was, so for us, we had the job of recording them, so we weren't a part of actually giving them the instructions for it. So that could also be a limitation to it, is how they perceive that as well. And as far as our statistical analysis, we use the graphs in the 2x2 table to determine which survey had the strongest association with the list, and we use these 4 characteristics here.
All right, so we're gonna get into some of our graphs that we looked at. Originally, we looked at all of our surveys that we had. So SWI, OWI, and SFWI, and we wanted to see how close they were in correlation as far as in relation to the list. So with our area under the curve, seeing that our SFWI was at 0.716, all the numbers were generally close, but we saw that SFI was a lot closer to SFWI. So in relevance, in clinical relevance, it will be easier as ATs to do one survey as opposed to having a participant sit down and take a 20-question survey compared to a 10-question survey. So if we could do that by just giving them the SFI and coming out with the same or similar outcome. So that's what we decided to do here. Okay, so we had 2 cutoff points for our SFI surveys, one being less than or equal to 94, and then the other one being less than or equal to 84. The reason we ended up choosing the less than or equal to 94 cutoff point is because our SFI less than or 84 had 100% sensitivity, which would rule in everybody to do the test. Okay, rule in everybody to do the less, which defeats the purpose of our research. Okay. So for our less than 94, for our less than, for the score of somebody had less than or equal to 94 would identify 69% of the people who tested negative on the SFI, which would then lead to them doing poorly on the less. For the people who had greater than a 94 on the SFI would then lead to them having a 75% chance of scoring positive on the SFI and doing having a positive score on the less. Importance here for our CI, we had 95%, with the lower limit being above 1, which is significant, and then having our odds ratio fall in between the 2 ranges made it even more significant. Okay, so we decided to take it a step further with our survey by looking at all of the items on the SFI to see which one had the chance of being a stronger predictor of just that one question that we could look at and have a predictor to say, okay, if they answered a specific number on this one, then they're more likely to perform poorly on the list. So we looked at the area under the curve again, and originally we saw that SFI 2, item number 2, had the highest AUC, which was 0.702. So we started off with that one, but then came to realize that its specificity was 100%, so it was going to rule everybody out. So we looked at the next highest one, which is going to be our SFI 10, which is right here. It had a AUC of 0.695. So we decided to focus on that one. This is the question up here. It is a psychosocial question, which is focused on personal impact and how it affects how the person performs. So right here, you see the raw score. I know Paige kind of touched on it earlier with their presentation. We originally started with the raw score, which is why you see the less than or greater than to 2, because it goes 0, 1, 2, 3, 4, 5. But to make it easier, we put it on a 100-point scale by just multiplying it, making it a total of 50 and then multiplying it by 2 to get the, yeah, you know what I'm saying. So here, if they were to score greater than or equal to 2, which is if they were to click on infrequent, occasional, frequent, or persistent, then they are likely to perform poorly on the list. But however, if they were to pick rare or never, then they have a likelihood of performing well on the list. Hope that makes sense. Excellent. Okay, so overall, our ROTC cadets performed poorly compared to other populations that we saw, like in our references that we had. And the reason that we feel like this may be the case, as Tawanda stated before, how they understood the instructions that they were given. So they may have misunderstood, like some people that we saw were jumping for height, not so much jumping for distance, which was a problem. Also, we could also look at their background. Some people may have had an athletic background compared to people who have never played sports before. So it could have just been their landing mechanics, because we had some people that landed really well and you'd be like, okay, maybe they played sports. And also, it also could be a possibility of the environment that we were in. So maybe if they felt like they were in an environment needing to actually jump off of something just besides a box, it could have played a part as well to why they were just jumping the way that they were. We saw that there was a strong correlation between cadets' overall wellness and the impact it had on their performance for the LETs as well.
And we found that an impact of negative life events strongly associated with a poor LET score. And also research tells us that brain circuits that regulate cognitive processes, emotional regulation, and physical factors all overlap with each other. So that could also explain that psychosocial variable as well.
Okay, so for our clinical relevance, ideally, we would want to give everybody a survey just as a baseline survey. So therefore, then we can use what we get on the SFI scores to hone in on who needs to do the less and who is at risk of having a lower extremity injury.
Yes, and also it says the LES test confirmation of suboptimal landing mechanics will justify intervention. So we're saying that the athletic trainer does the survey and then move on to the athletes doing the LES test. And then also as our treatment plan would be one of those intervention programs, which is why we mentioned the FIFA 11 Plus program, which is a ACL injury prevention program.
And ideally same for the sports metrics as well. So in conclusion, we recommend cadets who score low and perform poorly on LES start treatment to improve their biomechanics. Like we said, just one of those two, or I'm sure there's other ones out there that they can look forward to. And all of this is also clinically relevant because it saves us time as athletic trainers.
Yes.
That's all.